Good morning, everyone. And today is the last day. MashaAllah, time flies. So please join me in welcoming to the podium Dr. Alfonso Iorio. Alfonso is going to present to us his views, I guess, on clinical decision making and how to read an evidence profile. Alfonso, the floor is yours.
Good morning, everyone. So the evidence profile is something in between the evidence, the literature that we have appraised, and a clinical recommendation. And you may wonder why you need to check directly the evidence in presence of recommendations. And you may be right. When the recommendation is simple, you understand it, you agree on it, it confirms what you believe, usually you don't need to go and check the evidence. But many times recommendations, they don't say exactly what we expect and would imply a change in practice. In those cases, you may go by trust and you may look at who issued the recommendation, was on the panel, is a Ministry of Health recommendation, and no matter if you believe it or not, you have to stick to it, or instead you have a room for decision. In those cases, you may want to understand why a recommendation was issued. And in those cases, if the panel used an evidence profile, it's much easier to read that one than going back to the literature. So we will review quickly the main components of a guideline development process. To understand why a recommendation was issued, is important to know what was taken into account. And you'll see that we will find again the same component you identified on the very first day as a part of a clinical decision framework. And then we'll see how you in practice go from evidence to a recommendation. And hopefully you will be able to appraise a guideline as you do for a treatment, for a study about treatment or a study about diagnosis. We have encountered this pyramid already a couple of times, and we have reflected on the base of our evidence being individual studies, and then they being summarized in systematic reviews, meta-analysis. Now, the original version of the pyramid was presenting directly summaries on top of the systematic reviews. So things like Dynamed or UpToDate. In a more modern view of the pyramid, over the studies and systematic reviews, you have guidelines, not all guidelines, systematically derived recommendation. So the reason why guidelines were not in the pyramid is because most of the guidelines until a few years back were not evidence-based or not necessarily evidence-based. Was an alternative way of proposing action usable content, but was mostly expert opinion based. And indeed the concept in the beginning of EBM was that wherever you have evidence, you don't need guidelines. Evidence is enough. It's not enough to make a decision, but if you appraise the evidence, you take into account the component coming from the patient, from the healthcare setting in terms of cost and affordability, you don't need guidance, you can make decisions. So guidelines were mostly issued where there was no evidence, and when the only way was, okay, I've treated a few of these patients, that's I would do. And then he would say it's the same, and he would say the same, we sit together and we agree on how to go. With the growth of evidence and having so many studies and sometimes many multiple systematic review to appraise, then guidelines become important even in the evidence-based setting, because you have to find your way across many different flavor of evidence to be able to apply them to practice. And that's why we introduced them in this last version of the pyramid. Now let's continue on our problem-based learning and bottom-up process. So let's start from some guidelines, and let's try to see if we understand what they did. I'll take a guideline on breast cancer screening that was adopted a few years back here in the Gulf area by the Saudi Arabia Center for EBHC. Out of the recommendation, the guideline is on breast cancer screening, but there are many recommendations. I selected 5. One suggests screening every 1 to 2 years between age 40 and 49. You might be okay, and you might say, well, fine, that's what I do, I'll continue. A second recommendation suggests screening with mammography, between 50 and 69 every 2 years. And you may say, okay, or you may say, why I do every 1 to 2 in younger women, and then I decrease the frequency 50 to 79. And then a third recommendation suggests to stop screening at 70, not to screen beyond that age. And again, you may agree or you may want to know why. Fourth recommendation suggests to stop teaching girls and women to do self-breast examination as a single way of screening, and also suggests not to do clinical breast examination by healthcare professional as a single method of screening. So it's a kind way of saying don't rely only on that, do also the mammography, but the bottom line is if you want to do something, do the mammography. The clinical exam and the self-examination doesn't help. When it helps, it's too late. You find something because you skipped doing the proper screening. Now, one basic concept that you have to understand when it comes to recommendation and evidence in general is that there is a chance for an event, a likelihood of something to happen, and there is some confidence that we know about it. So I don't know how often it rains in Kuwait. I was able to see raining here, but I would expect it's not that common. Maybe I'm just wrong. So if you look at the weather forecast, it tells there is a 20% chance of raining tomorrow. You know, maybe you don't use the weather forecast. In Canada, you need, because you need to know what's going to happen during the day. The temperature can change 20 degrees during the day, and you may go out and then have to ship back your coat, or instead you go out in shorts and then you'll freeze going back. So they tell you there is a 90% chance of snowstorm or a 70% chance of snow. And then attached, there is also a confidence in the prediction. And we are 10% sure that the prediction is going to be correct. And you say, well, why don't you translate the confidence into the chance of raining? Well, because the two concepts are different. The chance of raining that I can predict is 1 in 4, 25%. And sometimes it's so clear, it's raining in Buffalo. And it rained before in Chicago. It's coming this way. So unless something really unexpected happens, it will rain in Toronto in 3 hours. Because I'm seeing from the satellite that something is moving around. Some other times, there's nothing like that. And it happens sometimes that the rain comes from something happening locally. Condensation from water that goes up from the big lakes. But it's unpredictable. So sometimes you know, it's 90% sure it will rain, or it will not rain. You still give a probability, because you know the rain can change direction at the last minute, but it's very likely to. Some other times it's not. So the probability, the confidence we know what will happen is different from the probability it will happen. You may express these with credibility intervals. You may say the chance of raining goes from 50 to 70. It's more or less the same. If you are unsure, you say the chance of rain goes from 0 to 100. If you are very sure, the chance of rain goes from 70 to 85. These express your confidence in the estimate. Is even more complicated to understand. So usually you prefer to say, what's the chance, what your confidence? Now, this makes sense, I hope, to you. When you move it to the medical and healthcare reasoning, if I was to tell any of you as a patient that the pill I'm going to prescribe you will give a 20% reduction in the risk of whatever, and there is a 10% chance I know what we are talking about, you would possibly decide it's time to change your doctor and go somewhere else. I mean, not only this treatment is not very effective, it's 20% reduction, and you might not be happy, but might be the best we have, but we are not even sure if it's true. And this concept of confidence in what will be the effect of treatment is a big conceptual step to have, but it's the base of all the need for medical research. Now, since you are already pretty bored of me talking of probability, I'll tell you how this is translated in guidelines, because guidelines tend not to push people back. So instead of putting numbers and confidence and probability, and you say, you know what, I'm not reading the guidelines, the attempt has been made to come up with 4 concepts, but if you think of it, it's the same. A recommendation can be, well, first of all, a recommendation can be for something. I recommend to screen for breast cancer, or I recommend against screening for breast cancer. That's easy. If you don't agree on for or against, we have no way of communicate today. Then you may say, I have a strong recommendation for, strong against. What strong means? Strong means I expect this recommendation apply to many situations, to most of the cases. And then we have weak recommendation. Now, weak doesn't sound good. So someone proposes to call the weak recommendation conditional. Some others say it's conditional, doesn't sound clear. It might be good, but it's not clear. Weak, I understand. Weak is, okay, you can do it, but not for everyone. Think about it before doing it. Conditional, put more accent on conditional on what? Well, conditional on specific situation of the patient. So the recommendation is there. I'm saying, I suggest to do this, or I suggest not to do this, conditional on the patient being severe, the patient being sick, the patient being rich and able to pay, and so on. Now, there is a flavor of what a conditional recommendation means for a patient, a policymaker, and a doctor. Let's focus on doctors, which is what we are. A weak recommendation means be more prepared to help patients to make decision that is consistent with their own values, and decision aids and shared decision making may come useful. So there might be some conversation around what to do. In a strong recommendation is next, aspirin for you, next, aspirin for you, next. Oh, you maybe had bled too much. We'll think about it, but most, they get the recommendation. Now, how we move from evidence to strong for, strong against, weak for, weak against, is what we said the first day about the decision process. We appraise the evidence. Now you should be able to appraise the evidence while driving and blinded. Not yet for diagnostic studies, but you'll get there this morning. And, but that's not enough. Then you have to add the consideration about cost, preference, feasibility, acceptability. Now, let's see if I can operate this one. Yes. In rating the evidence, we can use all what we have learned in this course. When it comes to guideline panels, some of them, they attended a course like this, some of the members, and so they could do just with what they know. Some other, they don't. And you tend to have a variety of animals on the panel. So you want a physician expert in that disease, you want patient, policymaker, you maybe want someone from insurance companies, someone from the lab if there is diagnostic involved, a radiologist, and so on. Some of them, they don't exactly know how to appraise evidence, or they were not exposed to this before. The GRADE working group is really more than organization, is a group of thinking, is a method to develop guidelines, but more than a method, is a large group, about 300 people that meet every year and try to develop the best way to help panel to go from evidence to recommendation. Is adopted by now about 100 organizations, including the WHO, NICE, SIGN, Cochrane. Was founded by Gordon Guyatt. I'm part of it. We will be meeting in Rome soon. And sorry, there is something wrong the way this works. So I saw slides changing on my screen. Did anything change there? No, okay. You should have told me before. I'm not sure what's going on. Okay, let's see if now goes. No. So I was telling you about the GRADE working group. Can you hear me this way? Yeah. And sorry for that. I didn't look at the screen, and on my screen it was going on. So you are really admirable in your capacity of resisting to any form of vexation and violence. Okay, good. Okay. Thank you. Yes. Yes, thank you. So, sorry for that. I had the pyramid, and then I had, did you see this one? Okay, so here we saw bottom up, you saw the recommendation, you saw the good, good. So we were, yes, okay, very good. So even the technician was very, very aware of where we were. I was the only one confused. Good. So it's a two-step process where you appraise the evidence first and then you incorporate the other dimensions. So you do the summary of studies, you balance outcomes, and then you account for cost preferences, feasibility, acceptability. I told you about the GRADE working group. Now, when it comes to the determinants of the quality, you know what we are talking about. If we have RCTs, we say that we start with high quality for treatment. I'm now in the treatment and screening field. So RCTs, high quality, observational studies, well, we start at a lower level. We know that there's residual confounding. Would be different if we were talking of prognosis. Observational starts high there. Then we have 5 factors that can lower quality. One, you know, is limitation in study design and execution, so risk of bias criteria. A risk of bias can decrease our confidence in the result, quality of the study. Inconsistency, it's a meta-analysis. We have studies all over the place, 1 against, 2 for, 1 neutral. We start being uncertain just because this repetition of the experiment show different result. Indirectness, we have encountered this. The patient is not exactly like ours. So we are less confident translating that evidence to a slightly different patient. This is very common in pediatrics. You have no idea what will happen in pediatrics with a new medication that was tested only in adult. You cross your finger and you go. You may reduce the dose, do extra checks, but you apply indirect evidence. Imprecision, the confidence interval crosses some identity line or some decisional line. And then we have factors that can increase quality. So if the effect is very large, have you seen yesterday with the beta blocker, 92% reduction in mortality? Come on, you start using beta blockers. Was wrong, but back then seems good. And there is, even if there is bias, even if there is confounding, and you try to guess what would happen if all the patient lost a follow-up were dead, well, still there will be an advantage, and actually will be bigger. In those cases where every possible problem with the study would still confirm the decision, you are more confident going that direction. And of course, we are all happy, more or less, to see a dose response. If you give 20 milligram, you get lowering of blood pressure. If you give 40, much lowering of blood pressure. 60, the blood pressure goes really low. 80, you kill the patient. Wow, that's medication work. There is a dose-response gradient. The more I give, the more the pressure goes down. I can use this to kill patient I don't like. That's a very strong suggestion that you are confident that works drug. You would not use a drug you don't think it works to kill someone. If you decide, if you get to that point, you want to be sure you get the result. Okay, so this is what you use for assessing the quality of evidence. Now let's go back to the recommendation. I'm not sure you can, if you can read, then really you don't need the slides. But this is the recommendation about screening in women age 40 to 49 and to screen every other year. So they looked at the body of evidence. There were, on this table, you have outcome on the rows. So you have breast cancer here, and then you have, oh, sorry, the pointer doesn't work. So you have breast cancer, then you have all-cause mortality, and then you have false positive. And for each of them, you have the studies, and you have the domain of risk of bias. So you have the indirectness, inconsistency, imprecision, publication bias. Is almost all good. After that, you have a judgment on quality. So you have low quality for mortality, high quality for all-cause mortality. Oh, thank you. You have low quality for mortality, high quality for all-cause mortality. This is breast cancer related, all-cause, and low quality in what we know about the false positive. The balance of these quality then translate, you have how many subjects did or did not the screening, and what happened to the treated and untreated, the relative risk reduction, the absolute risk reduction. And by looking at this table, you balance the outcome and you make a decision. Now, I'm really making it simpler. You'll see that between the evidence and the decision, there's something else. But in terms of the underlying evidence, this is the evidence that all in all, considering mortality for cancer, competing mortality, side effect, led to support this recommendation. So the way you go from evidence to the recommendation is looking at the level of confidence initially. So you have randomized study, you start high, observational, you start low. Then you consider all the domain of risk of bias. And after you have done this, you can start high and go down to moderate, to low, or to very low. The more defect you find in the body of evidence, the more you go down. Or vice versa, you can use the criteria to go up, and maybe you start from observational, you can still go down, but you can have instead large effect or dose response and you go high. All of this is tracked in the process. So if you wonder why they gave a strong recommendation starting from observational trials, you will find what the reasoning was. They considered low, they considered some characteristics of that body of evidence and went to conclude for high or moderate or whatever it is. And for example, if you look at screening with mammography at the higher age, why they decided not to recommend every year but every 2? Because in the other population, there was a strong high quality evidence for an impact on mortality. In this case, there is moderate quality evidence, and the gain is much lower. So there are no other effects. There is much less evidence on the other two, the overall mortality and false positive. So this consideration, the smaller sample size, less study, more uncertainty, moderate quality evidence, for screening every year compared to screening every 2 years, led them to say it's better to rely on a longer interval period. You can represent the risk of bias this way. You should have seen now this many times over these 2 days. But the bottom line is you translate it into how the evidence in all was judged. So you start at the study level, but then you use the other plot where you see the overall body of evidence. Inconsistency and imprecision. You judge, as I told you, from the spread of the confidence interval. Now, let's do an exercise here to wake you up, a bit of brain stretching. So here is a negative effect, here is a positive effect. This is the identity line, okay? So whatever is here has no effect. I want you to tell me which of the study I'm showing in a second is significant, which is the most precise, and which is the one you choose. So let's compare this study here and this study here. Which one is significant? The red one. Good. Which one is most precise? Red one? Good. And which you choose? Red one. Good. So you are all awake and agreeing. Let's try another one. The red one and the blue one. Which one is significant? Both. And which one is most precise? Blue. Good. And which one you decide? Well, the effect is here. This is a negative effect. This is a positive effect. Which one you decide? Red. So in this case, they are both significant. This one is less precise, but this one is the one you choose, unless you want to kill your patient with extreme precision. So in this case, well, precision counts, but it's not all, okay? You didn't get it. Because this is no effect. Let's assume we are preventing stroke. So on this side, treatment is better. On this side, placebo is better. So for this study, we are saying we have a significant effect, a bit imprecise, but using this drug, you get a reduction in stroke that goes very likely here. I didn't put number. Let's say it's a 50%, goes from 25 to 75 reduction. For this one, is very precise, but it gives you an increase in stroke. So you don't want to use a drug that gives increase in stroke. So this is less precise, but is on the right side of things. Okay? Good. Now, this one and this one. Which one is significant? Both. Which is most precise? Which one is most precise? The blue one. And which is your choice? Red. And you say blue? Anyone want the blue? You want the blue. Both? You can't say both. You have to pick one. The patient can't take 2 medications. You'll ask the patient if he likes more red or blue. No, you may ask the patient if there are, let's assume these 2 medications are identical, same side effects, same cost, even the pill is identical, same size, same form. You'll take the red. Why you take the red? Right, it's farther away from the identity line, so you don't know if the effect is here or here, but in many cases will be anyways better than using this one. Because this effect, yes, is narrow, but is narrow lower than that one. Okay? So precision counts, but it counts also where the effect is. Okay. Now this one, and now let's introduce green. And this one. So which one is significant? All of them. Which one is most precise? Blue. And your choice? Red, why you pick the red? I think you are right, but can you tell me why you picked the red? Yes, yes. So there is a very, the worst case is the same for all the three. So really there is no difference on which one may be worse. But the red can be better than the other. We don't know if it's better, but this is the kind of uncertainty that we like. Because it may be equal, but it may be better. Okay. There are a lot of very bad jokes on maybe equal, maybe better, but we leave them aside. So now, after having introduced the green one, we also introduce a second line. Who can guess what line, which line is that? What I'm trying to represent on screen now? Sorry? Oh, I just didn't hear. Is not an association line. This has something to do with patient preferences and values. What can it be? This is the identity line, no effect. This is the minimum effect I consider important. Say we are now talking of a medication to treat cancer, where we measure the success in how many weeks I gain, and we know that this medication is causing daily nausea. Every single morning you wake up with nausea. Now, here someone may say, listen, if I have to think that from now to death I will be vomiting every morning, I've not been pregnant yet, but many of you will have, and maybe you had pregnancy-related nausea. They tell me it's not nice to wake up every morning, first thing in the morning you go and you vomit, or you barf, whatever verb you prefer. So you may say, to take that time every morning to be nauseated, go and vomit, I want to have at least 1 month, at least 6 months increased survival. If not, I don't really care. If I only have to survive 1 week more, and I have to vomit all the time to there, I prefer not. So this is the decisional threshold. This is, if it's less than that, I don't care. Now you decide based on the decisional threshold. You have the red, you have the blue, and you have the green. Which is significant? The blue? All. For significance, you continue to use the identity line. I didn't leave it there to confuse you. I left it there because you need it. For significance, they are all three significant. FDA, they approved all the three. Now, which one is most precise? Blue. And which one you choose? Blue. And why you choose the blue? Yes, because it's the only one that ensures you get more than that benefit. Okay. Red. Blue. Which one is significant? Blue. Which one is most precise? Blue. And which one you choose? Blue. Why? Yeah, it's not crossing this line, so you are right, it does something. It does something I'm interested in or not? Oh, well, yeah, it's on this side of the identity line, so it does something that as a doctor I'm interested in. It increases survival by 5 days. But the patient tells me whatever increases survival less than a month, I don't care. Yes, the one above can do harm. So this is one of those places where there is no right decision. And if you were to tell me I can't decide, I have to ask the patient, I would take it. But for sure, this one, no. Because this is not giving, you have to tell your patient, oh, I understand you want at least 1 month extra of life to accept this rate of vomit. Unfortunately, the only medication I know for sure will increase a bit your life expectancy is not is not making you to live 1 more month. I have another one. I'm not completely sure if it works. He might even do some harm to you, or he might just give you a small increase. But if you are lucky, it might give you a lot of increase in life expectancy. So either we do nothing, or if this is your decision threshold, you do nothing, or you try this one, knowing that you try. And maybe this is not FDA approved, and we have no option, but this one doesn't work. Is significant, is precise, doesn't make any difference for that specific situation. This one is not significant, is not precise, it might not be available, it might help, might. That's where you say there is some possibility the factor can be as high as increasing your life expectancy by 3 months. Unfortunately, I have very little confidence about that's being true or not. Let's see if I have another. Yes, I have another. This one, and this one. Now the red is going on vacation and has moved apart. So which one is significant? All of them. Which one is most precise? And which one you choose? Red, because you have no idea, can even give you eternal life, right? But for sure is more than that. It's not precise, but is on the right side of things. Okay, let's stop here. We could go on forever. There are many combinations. Did you get the concept of what you have to look at? So I hope that next time you look at a forest plot, you will have a little more fun. They are never so fun. They are not colored. I'm trying to convince Cochrane to make colored forest plot. Maybe we read them better. So publication bias. Have you discussed publication bias yesterday in the systematic review? Good, so I'll skip it. Indirectness. If you think of the PICO question of your patient is in the red area, and the PICO or PICO question of the systematic review in these blue circles, you can have a situation where they are all in or out, or maybe the population is not exactly the one that matches your need, or maybe the outcome is slightly different, and sometimes there is full overlap. So I hope that you'll get through these 3 days that in appraising the literature, something is what you do judging the paper, and something is when you judge, does the paper apply to my patient? Now, when it goes to mammography screening in women older than 7 to 74, the reason they recommended against is that there is no evidence about the effect on mortality. Breast cancer mortality can go one way or another. False positive, there's no evidence, but most of all, there is not one single study showing improved survival. So why bother? And for self-breast examination, for example, again, there were only 2 studies, very few patients, moderate quality of evidence, and no evidence that there was any difference. So these profiles are published with the guideline and may help you understanding why the recommendation went that way. Let's finish by looking at what other components do we consider. After the evidence, we also take into account values and preferences, resource use, and all the rest. And they get into the balance. Some considerations are for, some are against. And depending on how they are balanced, you end in concluding one way or another. The problem is that it's not so easy. It's easy to count dead body and to have profiles and to have studies, but on all the other aspects, you don't have so clear numbers. So what GRADE does, uses a evidence to decision framework where all the components are considered, and the panel, during their work, they check what they think about all of these. So that if you read back what has been discussed, what was considered, and what the group discussed, that is in this side, in a form of notes, you may say, okay, they discussed is a priority. If they say no, they stop. Are we certain that the benefit outweighed the risk? And then you say yes, no, we don't know. And there are here the consideration that were done. And you go down the list and you consider all of these aspects. Benefit and harm, quality of evidence, values, resource use, equity. Is there any patient that is less likely to have access to care if we adopt this intervention? Acceptability. Will patient do what we recommend? Feasibility. Can I order a PET? If the PET is not available, it's pointless to order in Saudi Arabia to use a PET for diagnosing recurrence of breast cancer if the test is not available. And you can recommend to buy one, but not to use it. And then you get to the recommendation. So all this process ends in a recommendation against or for, weak or strong. And when you have filled all the form, there's a sort of a plot that shows you a colored square and let you see in a visual if all goes in one direction or if different component goes in different direction. I might try to make an interactive presentation for next time, and you end in having a recommendation. Now, this is for most cases. There are specific cases where there are sort of exceptions, like everywhere in life, and there are situations, life-threatening situations, or situation where the benefit is uncertain, but for sure there is harm. Or the two drugs, the two treatments are almost equivalent, but one is clearly less risky or cheaper, where you give a strong recommendation, even if is not directly stemming from the evidence. So these 5 exceptions, where you give a strong recommendation based on weak evidence, are described in a paper with examples. I'm not reading them, I'm just giving you 2 examples. One is a WHO recommendation that was done for using oseltamivir for avian flu. And the evidence was low, but the disease had a high mortality and there was no other alternative. And the side effects of oseltamivir were very little. The cost is high, but there were few cases. So WHO recommended to use it. Strong recommendation, weak evidence. You may agree or disagree. In the exception, there's always a chance of agreeing or not. But that's the reasoning. And the reasoning is explained. The disease is highly deadly and we have no alternative. In this other case, this is a American College of Chest Physician recommendation. Patient with idiopathic pulmonary fibrosis, they recommend, and there was a discussion about do we use azathioprine and prednisone together. Now, the evidence about benefit was very uncertain. Few case series, few patients treated, some doing better, some doing worse. For sure, everyone had side effect. So, end of the day, they said, well, we are not sure if it works. And really, it's not that it may also, it may not work. It's not really clear. There is not one single well-done prospective study, just case series, but there is clear evidence, even in case series, that it does a lot of harm. So they recommended against using it, and was a strong recommendation. With some people unhappy, of course, but was a strong recommendation. And the concept was the benefit is very uncertain, the risk is clear. Now, the 3 basic concepts to bring home from this presentation are that appraising the evidence is not all you need for a clinical decision. We have said that already on day 1. And this is not to take away value from this course. It's critical to be able to distinguish a good and a bad study. It's critical for you in making your clinical decision making. It's critical particularly for me and for Fahd, because that's what we do as a job. But it's not all. After you have found what works and what doesn't, you still have to bridge the gap to what's best for that patient. So the second take-home message is, you may not do your own appraisal, you may rely on guidelines, you may rely on summaries of evidence like UpToDate, like Danamed. You still have to do your job or collecting the other information. Cost may be different patient to patient. I had not this problem in Italy. In Italy we have a universal health care, and when I was practicing there, really every medication and every intervention could be offered to everyone. Now in Canada, after I'm done assessing my patient with bleeding disorders or hemophilia or thrombosis, I assess the patient, I find out what's the best treatment, then I have to say, oh, by the way, do you have a drug plan? Yes, no. Well, then the option restrict. Which drug plan do you have? I didn't know when studied medicine in Italy that I would have needed to know about which medication is covered by which drug plan. But there's no point for me to prescribe apixaban if that patient can't get it, because, I mean, if he's willing to pay, he can pay every month $100 to get that medication, but he can have it only if he has some insurance. That's not in the guideline. That's not even in UpToDate. You have to know, and we have our tables with the insurance that cover and not, and we use that as a part of the decision. I'm making it trivial, but of course, you have to take into account other things. The patient who had his father dying of cerebral hemorrhage gives a different weight to the bleeding complication of the one that had 3 relatives, maybe a young brother dying of pulmonary embolism. The second one doesn't want even to think about having a clot. The first one says, you know, I had a clot in my leg, I can have another. I don't want to die like my father did with a bleeding in my brain. The third point is that evidence does not make decision, and even the GRADE approach to guideline development, and I'm not saying that GRADE is the best, but it's adopted by 100 organizations. So if it was really bad, we would have done a great job in convincing them using it. So I think it is self-explanatory, but still a process like that has exception. That's why I showed you there are at least 5 situations where you do exception, because the beauty of the job we do is that we have exceptions that keep us in need of feeding our brain and making it work. So these are my 3 conclusions. I hope that you stretch your brain with the exercise, because now you'll need it all for diagnosis, and you will be amazed by next talk, but you will also need to use your brain a lot. So stay tuned and recaffeinate yourself if you need, and I'll see you